This is one of the largest studies aimed to describe the impact and pattern of infections in a comprehensive population, including all kind of next generation B-cell-depleting anti-CD19 and CD20 immunotherapies in a real-life cohort. So because there's a lot of data in literature about CAR T-cell therapy or bispecific antibodies, but not as much in ADC or ADC or naked AB, like such as tafasitamab that we used, that we kind of studied in this analysis. This analysis is the main focus. The main focus is infections, the infections events. In our analysis, we had 158 patients for a total amount of 195 immunotherapy lines, and based on these lines of immunotherapy, patient developed 162 infections events. Every patient had, not every patient, but some of the patient had from 1 to 6 infection events in a 2-year period of time. So in this period, we saw that mainly infections events were developed in the first 100 days. Like 76% of infections events were in the first 100 days. 59% were in the first 30 days. So this is for us. This is significant because for those kind of immunotherapies, we can see that in the first period, in the very early time from the starting of immunotherapy, we have the main risk of infection. We don't have to forget that. Mainly also for CAR T-cell therapy, we have a risk of infection that can last also to more than 100 days. So the prophylaxis strategies have to be really focused on the patient and have to be continued during this amount of time. We also focused and concentrated on the cause of death on this cohort of a patient, as is shown in literature. Also in our study or in our analysis, lymphoma progression is the main cause of death for our patient. But infection events were the first non-relapse mortality, non-relapse correlated mortality. And for the impact that has on I think on the clinical impact that has this study is that we have to improve on we are not only improve but like focus on the prophylaxis, I guess, because this is a multi-center study, so we had like heterogeneous strategies of prophylaxis, heterogeneous strategies of treatment. But we saw that infection events were mild to moderate. So and even if we had 162 infection events, they were still manageable. Only 6 patients had grade 5, so a fatal infection event. The others were kind of grade from 1 to 4 and were still manageable in the clinical setting or not. Also outpatient. The prophylaxis were mainly on antiviral. Like we 97% of immunotherapy lines received antiviral prophylaxis, 99% anti-pneumocystis prophylaxis, whilst for antifungal or antibacterial, this was the choice of the prophylaxis on those kind of infection were more like it was center guided, like every center had their own disposition, their own strategies of prophylaxis, also based on the kind of patient that they had and so the characteristic of the patient too. I think this is our first goal. We see that by the results of our studies, of our analysis, we couldn't find a main principal risk factor for infection, because this is because of our limits of the study, because it's a retrospective study, because it is a multi-center study. That is this a strength of our study, but also limit, because as I was saying, we have heterogeneous population, heterogeneous strategies of therapy. But we didn't find one risk factor that was linked to the development of infection events. We found that a correlation, if we want to see like this, between the administration of Ig immunoglobulin IV and the infections events. This correlation is reversed, like the patient that developed an infection received more Ig immunoglobulin, endovenous immunoglobulin, because they were more fragile as patient.